MSK pathology, achondroplasia, osteoporosis, osteopetrosis, osteomalacia and rickets, osteitis deformans or Paget's disease, and avascular necrosis of the bone. So finally, we've reached, in my opinion, the crux of musculoskeletal pathology. So first, let's start off with achondroplasia. Achondroplasia is dwarfism. And what it is that you have failure of longitudinal bone growth, right? So we have failure to produce long bones. And remember, long bones are formed via endochondral ossification. So they have failure of endochondral ossification. So the patient's going to present with a normal appearing, like they will have like a normal like sized head because their skull bones are their flat bones. So all their flat bones are going to be normal, but they'll have short limbs, right? Because membranous ossification is not affected, but endochondral ossification is affected. So remember, it's a failure of the endochondral ossification. Now, what they want you to know specifically is that it's a activation of FGFR3, okay? Now, they're usually sporadic. So greater than 85% of mutations occur sporadically. So you're usually not going to see like a family member that has achondroplasia as well. But what you also need to know is that this is autosomal dominant with full penetrance. So if the patient has homozygosity, that's lethal. So any patient that has achondroplasia is heterozygous, okay? Because if they are homozygous, they would not be born. It's lethal. You have to know that. Every single patient with achondroplasia is going to be heterozygous. All right, it's associated with increased paternal age, so the father's age is going to be high up, okay? Now, next is going to be osteoporosis. Osteoporosis is going to be trabecular or spongy bone and cortical bone loss, okay? But the big thing here is you lose that mass of bone, but you have normal bone mineralization, you have normal lab values, okay? Normal lab serum calcium, normal phosphorus, normal PTH, normal ALP, everything's normal. So it's very odd, right? So osteoporosis is going to be the loss of bone mass, both trabecular or spongy and cortical bone. But remember, it's going to be normal lab values and normal bone mineralization seen, okay? Now, osteoporosis, what they want you to know specifically is that the trabecular bone, it's more at the trabecular bone where you lose the mass, and it causes trabecular bone thinning, okay? So what causes it? It usually most commonly caused by increase in bone resorption. Okay, so that tells me that there's an increase in activity of osteoclasts. So increase in osteoclast number and activity. And it's usually due to a decrease in estrogen levels secondary to old age from elderly women who are in menopause. Another risk factor is going to be cigarette smoking as well, along with steroid usage and alcohol usage and other things like that. But the highest yield one is decrease in estrogen levels. Whatever decreases your estrogen levels, usually menopause, old age, cigarette smoking, steroid, and alcohol use. Those are the highest yield ones to know. Okay? Now, something else they want you to know is how do you diagnose this? You're going to diagnose them by a bone mineral density scan, which is known as DEXA. Okay? If you see a T-score of less than negative 2.5, then you know you have a diagnosis of osteoporosis, okay? One-time screening is recommended for all females at the age or greater than 65 years old, okay? Because that's how common it is. And prophylaxis that we could do to kind of curb osteoporosis presenting earlier on is giving them calcium and vitamin D supplementation, but also weight-bearing exercises is protective because when you weight-bear exercise, it helps increase bone mass. Now, some treatments that can be helpful is going to be bisphosphonates, right? The endodronate. Another one could be teriparatide, which is a PTH analog, but you have to give it in a pulsatile manner for it to have an anabolic effect. And then some SERMs, like raloxifene. Denosumab is a monoclonal antibody against rank L that you can provide as well. But remember, these are sketchy video stuff that you can know about osteoporosis. The patients can present with back pain because the osteoporosis can affect the vertebral bodies and cause vertebral compression fractures. So vertebral compression fractures are highly associated with osteoporosis. And what that's going to look like is acute back pain, loss of height, or severe kyphosis. Okay? Now, remember, vertebral compression fractures don't have to occur due to severe trauma in patients with osteoporosis. It could be just anything as like lifting up something like heavy from the ground that can cause a vertebral compression fracture. All right? So, remember, overall, osteoporosis, it's very, very high yield to know it, and it's pretty easy to know, okay? Next is osteopetrosis. Osteopetrosis is the opposite. It's failure of normal bone resorption. So you have essentially defective osteoclasts, and that leads to thick, dense bones, okay? And they call these stone bones on x-ray. So on x-ray, you're going to see very, very white bones because they're so thickened. The issue is that they become so thick that it goes into the trabecular bone and you start to fill in the bone marrow spaces. So the marrow starts to be taken up and you get pancytopenia and extramedullary hematopoiesis. This is very low yield. Okay, osteopetrosis is very low yield. Next is osteomalacia or rickets. This is defective mineralization of osteoid, okay, and that's osteomalacia, or cartilaginous growth plates, which is rickets, okay? Rickets is only seen in children. Osteomalacia is usually seen in adults, and it's most commonly due to vitamin D deficiency. So if you have vitamin D deficiency in a child, it's going to be rickets. If you have vitamin D deficiency in an adult, it's going to be osteomalacia. And remember, it's defective mineralization of osteoid. That's kind of the key takeaway here. Now, what are you going to see? There's a lot of associated pathologies with osteomalacia and rickets. First, you're going to see epiphyseal widening, okay? And you can also see metaphyseal cupping and fraying in rickets. You'll also see in children with rickets bow legs, known as genu varum, so they'll have bowed legs. And they can also have a bead-like costochondral junctions, known as ricketic rosary. And look up what ricketic rosary looks like on X-ray and through the skin, because it's also a physical exam finding that you can see just through the skin. It's just a bead-like assortment near the lateral portion of your ribs. It's known as ricketic rosary. All right. Now, once again, it's usually due to decrease in vitamin D. And when you have decrease in vitamin D, that means you have a decrease in serum calcium. And so you have an overall increase in PTH secretion, which leads to an overall decrease in serum phosphate. Okay. So you'll also see hyperactivity of osteoblasts because you want to build bone. And so you're going to see increase in ALP. So for our osteomalacia and rickets, the things that you need to know are specifically decrease in vitamin D. Okay. Which leads to a defect in mineralization of osteoid. Moving on to osteitis deformans, this is known as Paget's disease of the bone. This is high yield, okay? What they want you to know is that it's a disorder in bone remodeling. And so it's going to be caused by an increase in osteoclast activity, which is then followed by an increase in osteoblast activity. And that forms very poor quality bones. All right, so it's not only osteoclast and not only osteoblast. It's first osteoclast and then osteoblast. So both are affected, and it leads to poor bone formation and a disorder of bone remodeling. Now, serum calcium, phosphorus, and PTH are all normal. The one key takeaway, and it's very high yield, I can't emphasize this enough, is that in Paget's disease, you will see an elevated ALP. Okay, you will have an elevated ALP. You're going to see a mosaic pattern of woven and lamellar bone. Okay, another way they could just say that is just like, instead of mosaic, they could say like scattered pattern of bone. And you're going to see potential association with high output heart failure. Okay, so increased osteoclastic activity is going to present with mosaic pattern, and you can have an associated with high output heart failure. All right, the patients could say, hey, my hat size has been increasing. And the reason behind that is because you're going to have increase in skull thickness. And because of that increase in skull thickness, it could present with hearing loss as well. So remember, the stages of Paget's disease is going to be first osteoclast, then osteoclast and osteoblasts, and then finally only osteoblasts. Okay? Now, I want to give you kind of the 5 main key takeaways for Paget's. The first one is not associated with the 5 main one. It's just the end-all be-all for Paget's is that all levels are normal except for ALP. That is going to help you differentiate and pick out Paget's disease of the bone in a question stem. So all levels are normal except for ALP. Now let's get into the 5. First thing you're going to see is mosaic weak bone with cortical and trabecular thinning. So mosaic weak bone with cortical and trabecular thinning. You're going to see an increase in skull size. You're going to see local warmth with an increase in output heart failure because it's a high output state. So local warmth with increased risk of output heart failure. Number 4, cortical bone thickening and enlarged vertebral bodies. That's another odd thing that they say about Paget's. And number 5, excessive and disordered bone formation. Okay, and that's kind of what triggers all of that. So 1, mosaic weak bone with cortical and trabecular thinning. Increase in skull size. Local warmth with increased risk of output heart failure, high output heart failure. Cortical bone thickening and enlarged vertebral bodies. And lastly, the overall idea is excessive and disordered bone formation. You will have normal levels of everything except for elevated ALP. Okay, it cannot be clearer. Next and last is avascular necrosis of bone. Specifically, when we talk about avascular necrosis, they like to question about the femoral head because it's the most common site of avascular necrosis. But all avascular necrosis is infarction of the bone and its marrow, and it's very, very painful. It's literally just necrotic material, like your bone is rotting inside your body. Okay, so most common location is the femoral head, and it usually is due to insufficiency of the medial circumflex femoral artery. They want you to know that the medial circumflex femoral artery is usually involved in femoral head avascular necrosis. They will also ask about the causes, and the causes are very important. It can be caused by glucocorticoid usage. That's high yield. It can be caused by sickle cell disease, because sickle cell disease can cause microvascular occlusion. It could be caused by trauma, obviously, which can cause like a break or fracture, and then that can break off the blood supply from the medial circumflex femoral artery. Okay, there's a lot of different causes. Gaucher's disease can be causing it. Skiffy, leg calf Perthy. Okay, but remember, glucocorticoids, alcohol use, sickle cell disease, and trauma are probably your most high yield ones. Lastly, your necrosis of the hip can be seen on x-ray. So if they show you a crazy CT scan or MRI or x-ray, you can visualize the necrosis. So take a look at one bone compared to the other, all right? And make sure that they look the same. If they don't look the same and one looks more necrotic, then you have pretty much avascular necrosis of the bone. So let's do a quick overview of all of this so that we fully understand what's going on. First, osteoporosis, that's just decrease in bone mass, right? They have all levels normal. Paget's disease of bone, this is abnormal mosaic bone architecture, and they have increase in alk-phos, solely increase in alk-phos. Osteitis fibrosis cystica, this is due to primary hyperparathyroidism, so this is elevated PTH, which is very important, and you're going to see brown tumors and subperiosteal thinning. I know we didn't cover it now, but we covered it in endocrine. But remember, elevated PTH and osteitis fibrosis cystica because of primary hyperparathyroidism, and you're going to see brown tumors with subperiosteal thinning. That's something that they love to ask about. All right. Next would be secondary hyperparathyroidism. Remember, we didn't talk about it now, but we talked about it in endocrine. You're going to see an overall decrease in serum calcium. That's the key. Okay. It's the only time where phosphate and PTH are both elevated. Okay. And it's usually secondary to chronic kidney disease. Next is osteomalacia and rickets. The key thing here is that you're going to see decrease in vitamin D, which leads to an overall decrease in calcium, right? And that causes PTH to be elevated, and then that leads to an overall decrease in phosphorus. ALP will be elevated as well because of osteoblast activity. All right, but it's vitamin D deficiency. So that's pretty much what you need to take away from these bones. The last thing I will say is that, although it's not in here, you have a child with fever who has refusal to bear weight. So anytime that a child is refusing to bear weight and they have a fever, then you should start thinking about osteomyelitis, because osteomyelitis in children who can't speak usually will present with not wanting to bear weight because it's so painful, okay? And it usually affects the long bone metastasis. All right, so this is our bone pathologies, and we're going to go into the bone tumors next.